Good afternoon. Thank you all for joining today. Thank you for coming to the Think Surgical TMINI Live Surgical Demonstration Symposium.
Just cut off.
I'm coming from Fremont, California. I'm joined by a great faculty, Charles Lawrie on my right, Miami. We have DA Rubin, who's going to be on the camera doing the live surgery out of Baylor. And then Eytan Debbi from HSS will be joining us. He's just running a little bit late from another talk. And then John Tiberi coming from California as well. So we have a great faculty. Look forward to having this be interactive, and we look forward to starting with a live surgery, which I think will be a great demonstration. So again, here are the faculty and the disclosures. Our agenda is we're going to have a quick introduction about TMINI, the Miniature Robotic System. We're going to do the live surgery with DA Rubin, and then we'll go into the PowerPoint didactic presentation with Eytan Debbi talking about why robotics now, why TMINI fits for him. Dr. Tiberi will show his functional alignment workflow. So TMINI can be both compatible with your KA techniques or your functional balancing alignment workflow, so we'll show both. And then Dr. Lawrie will talk about his experience using TMINI with the Zimmer Persona platform. And then if there's time, I'll talk at the end about implant agnostic robotics, really open platform robotics, and how it can help efficiencies in your ASC and your hospital. So that's our agenda. The TMINI Miniature Robotic System, if you're not familiar, is novel. It's state-of-the-art. As you can see on the left animation, it is handheld, completely sterile, with a single console across the OR table, as you see in that middle picture, using vertical space to see the arrays and the robot. So really unintrusive into the OR, much more friendly to OR protocols and workflows, and easy to integrate. Easy for staff, easy for surgeon. Easy to, again, perform these total knees regardless of your surgical approach or your alignment philosophy. And lastly, it is CT-based. It is a 3D planning workflow. You can see on the right, so you can plan this ahead of time and then make intraoperative changes on the fly based on whatever, again, your alignment philosophy would be. So we'll go into more depth of that with the presentations later. ID Hub is the proprietary data bank that Think Surgical uses. It has the most implant systems and design philosophies of any orthopedic robotic system currently available in the U.S. in it, so that it has all of this information so that a surgeon can choose the implant of choice, right? We are not held hostage to a specific robot and a specific implant. Surgeons now can choose to pair their preferred robotic platform with their preferred implant, giving us the ultimate choice. So with that, we're going to move to our live demonstration.
All right. Thanks, Alex. Hey, can everyone hear me?
We can, yeah.
Awesome. Hey, well, thanks for tuning in. I'm DA Rubin. Excited to get to show you surgery here at our hospital in Arlington, Boscia. This is the team. This is kind of our OR setups. You can see robot screen accessible. Can reach it. The receiver high above, unobtrusive, out of the way. This lady's very nice, on the younger side, 50-year-old female, tricompartmental end-stage arthritis. I think a great candidate for unrestricted KA, a medial pivot knee with press fit fixation. I do utilize a medial subvastus approach for 95% of the knee replacements, so that's what we're going to do today. Just to show you a little bit on the planning side on the screen, so you can see here my resection amounts. We'll kind of start at the femur. So as you can turn, can pan through, appreciate amount of osteophytes posteriorly that you. Obviously, for those familiar with unrestricted kinematic alignment, the resections are set. So we take into account implant thickness. We don't have to worry as much about the kerf of the saw blade because that's factored in. But on the femur, 7/6 with this particular Medactis spherica implant is on the femur. On the tibia, I recognize the resection differences, say 7 and 8. Don't get too hung up on that. The reason for that is my landmarks are in the deepest point of wear, which is obviously not the traditional location for unrestricted KA, where you'd put it at the midpoint of the slopes. And the reason for that is that if I decide to pivot to some functional alignment principles, which happens, 15-20% of the time, given the deformity or the patient, the changes that I make, I think, are more accurately reflected in that regard. So this plan was created, last week at lunch in clinic. I looked at a CT scan of the tibia to get my medial proximal tibial angle to make sure that my VV was appropriate. Planned resection from a proximal distal. I usually take an extra millimeter or two just so that I don't have to recut the tibia, and I don't mind putting a 12 or a 14 poly in if that's what's called for, and then try my best to match the posterior slope within reason unless there's wear. So anyway, this is the plan that we have. For unrestricted KA, the joke is the surgery's pretty much done. All we have to do is execute this plan. There is no gap balancing principles that we're going to use in this surgery. You certainly can make changes to it. We can kind of talk about when you do that in the workflow. And then just before we get going, I like to look at the eye in the sky, make sure that we can see well. So the tibial array is going to be here, femoral array is here. Little trick is, I think, to cheat the camera where when your extension, the boundary is here, come up to flexion, and it can still see well enough to make sure that it can see all the pins. So anyway, with that, we're gonna get started. Any questions thus
DA.
far? Yes, sir.
Quick question for you. I just want to ask in the audience, how many surgeons are doing kinematic alignment in the audience? So a number of you. Okay. And so, DA, just curious, how has using robotic technology helped with your planning and execution for kinematic alignment compared to using calipers or other things?
For sure.
How do people?
Yeah. Like most people doing KA, was first exposed to it, obviously unrestricted KA with Dr. Howell's teaching, manual instrumentation, and had success. Patients loved it, but I did have, I didn't like the fact that I'm not as accurate as a robot, so I had issues with having to re-resect, and it's fine as long as you catch it and pick it up, but I was pretty earnestly searching for a way to try and get it right the first time every time. I had had prior robotics experience, so I knew that technology existed, just not with the knee implant that I wanted to use. So tried a couple different iterations and different enabling technologies, and then came across Think, and it's been a perfect marriage in that regard. So I mean, I very, very rarely have to make a recut. I mean, maybe once 3 weeks, once a month type thing. So yeah, it's been a great marriage.
I think that is an important feature of the CT-based planning, because that's been my experience too, DA, and I assume the rest of the panel as well. With that planning, you just don't have to recut the tibia. It's accurate. If you're planning for 1 degree of varus in the tibia, it really seems to be quite accurate, and you're not taking too little, you're not too tight, wishing you had a smaller liner that doesn't exist, because the CT lets you plan so accurately. So similarly for me, have not had to do any tibial recuts, which is obviously hugely time savings and just much more accurate. Shows the accuracy of the system.
Certainly, and as I mentioned earlier, I like to take a few extra millimeters of tibia, just because I have no issue with putting a bigger poly in, and being able to spare a recut, I think, is always is really nice. I mean, the important part certainly is the varus valgus and the slope. That I recognize there's probably many surgeons more skilled than I, but I wasn't able to nail it every time. I feel like I was recutting when I was doing manual, maybe 20% of the time, and was just looking for something that I knew would be more consistent and reliable.
Right. With the KA approach, we're not all as good as Steve Howell with doing that technique. And with that approach, you have to be able to do recuts. So it's definitely nice with a robotic platform to eliminate that step. And the other thing is obviously the eyes in the sky. Thanks for showing that. Just going to ask the panel if they have any comments in terms of your experience with other robotic technologies, having the ability of having that camera directly overhead, having the arrays and the robot point directly overhead, just using that vertical space so that your assistant's not trying to dodge out of the way. You don't have to interrupt your surgical workflows. How have you guys felt about the overhead camera system?
I'll just say at our shop, our ORs are quite small. It can be really challenging to get, the camera system on the side of the room, and then it's a little bit of kind of twister to kind of get everything in line. Everyone's kind of backing up, and having the camera right above allows really for the whole team to just be there the whole time, and you almost don't feel that the camera system's above you, right? And you can even see here, the camera system, you didn't even see it, right? It's up above, right? It's nowhere near or in the way. You don't even see it in the view.
Yeah, I would just add, for those of you that are used to using other robotic systems or you're seeing them in the OR, the first time you walk into the OR for a TMINI case, you have this thought in your head, like, where's the robot?
For sure.
And the staff feel the same way, because it really is small footprint, very unobtrusive, so it's been great.
Yeah, we look in your ORDA, and there's so much space in that OR. You don't have things crowded in the room, which is great.
It's cutting in and
I
out.
agree completely with the overhead camera is a huge advantage. It's kind of threefold. I mean, one thing is it's closer to you, and as you get experience with any technology, it's easier for you to make an adjustment if you need to, which doesn't happen often. But with other systems, you're asking someone else to do it, and that just gets frustrating at times, takes longer, etc. And the other is it's just out of the way. out of the way of things you need to do, move around, and also out of the way of being obstructed. There's really no line of sight issue for your assistant or for you. It's a significant advantage.
And these trackers are also active trackers, whereas the other robotic systems all have passive trackers. So you can get dirty discs on those other systems, and then all of a sudden the camera's not going to see what you're working on. This, I've had blood all over the trackers before, and they still seem to see fairly well.
It's one of the first things I did when I started using this, was test it that way, and I was impressed.
Yeah, it really makes no sense to have the camera behind your assistant and have those line of sight issues. It's hard to believe that all the other systems are doing that, but this, with the overhead camera, you can do your normal workflows. Your assistant can be in the same place using the same retractors. You don't have to change anything. One of the things that I've liked about the robotic technology is number one, thanks for doing the sub-VASIS approach.
Yeah.
Other panel members doing sub-VASIS. What's nice about using this robot is, even though you're using arrays and other things in robotic technology, you can use whatever surgical approach you want to. It's friendly for all of those different approaches, not just alignment philosophies, but also different approaches. You guys doing some sub-VASIS as well? Not correct.
Yeah, and I actually don't, so I'm actually here learning myself and watching it being done. It's making me very excited, so it looks really great.
You take notes. It's okay.
Taking notes.
Yes.
Perfect. All right, so
But I do the similar pin placement. So I do this pin placement system here where I put one in the femoral ones are intra-incisional for me as well. And I do the extra incisional tibia pins. I think you could probably, there's probably other panel members that do some other version of it. But this is similar to how I do it as well.
So one thing I'll do kind of before we get to the next step is kind of again go to the overhead. So an inflection rather, it can see pretty well. Make little adjustments here. Oh, riding dirty. All right, I'm happy with that. I think we can rock and roll.
What's nice about putting the array pins there is that the femoral pins sort of act as a soft tissue retractor.
All right,
so it
working to
really
get the hip
exposure
center here.
throughout the
All right,
case.
picked it up.
So that move
See
was
that
really quick,
collateral
DA, but
again.
that was
Thank you.
quick flexion of the hip, just getting the femoral flexion extension access, but very quick maneuver. If you blinked, you might have missed it.
All right.
Yeah, I think for
Perfect.
me, that
So
was a new maneuver for
This
me
is the
to see, so that
digitizer,
was easy.
which is what we use for registration. You can go whenever order you want, femur or tibia. I typically work from the tibia coming up, both with registration and pin placement. Start with the gross registration for those familiar with robotics. It's a pretty similar workflow, doesn't take too long.
So no foot pedal with this system, no product specialist who has to advance things for you. It's all surgeon driven. It's all in DA's hands.
Get
So
the
that
malleolar points,
ergonomic tool, there are two buttons where you can acquire
one
points.
along the tibial shaft. Then we'll start with
Another-
our fine registration.
Another point about the overhead camera system is you have great exposure. You don't really need an assistant, but if you did need someone to hold a retractor for you, you could easily reach around and grab that lateral retractor and not block that tibial array because you've got that overhead system. So, it's much more conducive to that than having it placed elsewhere.
And with his exposure, the knee, great exposure, DA, but you can see how he doesn't have to move the leg, change position. He can
All right, so
register the
registration
tibia
went
pretty
through,
easily.
can really touch multiple places. Obviously, under 0.5 millimeter, I have no qualms or concerns with. I'm at the point now, honestly, where if it passes registration, I don't even check this anymore because I know it's going to be right on. So here, online, looks good. So I'll confirm. Move on to the femur.
You know, one thing is with this digitizer, it is measuring the distance
to
to the
troubleshoot
registered
the-
bone. So on the
troubleshoot
tibia,
my audio?
you could put the digitizer on the
Just keep
cartilage.
talking, no
and then
problems
go
with
through.
that. So just marching up here on the femur with registration, like I said, pretty standardized stuff.
I think having the trigger in your hand is a huge benefit as compared to either someone else doing it for you or the foot pedal. It's all just in one location. To me, that was a big benefit.
Much faster, much more efficient. I agree. You can see how quickly you can do it.
I just want to point out to anyone who doesn't have a robotics or really any
I can-
image-based navigation experience that the value of the CT here, DA's doing this, and we all as surgeons think we're perfect, but we're not. And even if you've done tons of these, you can still make an error in registration. And if you don't have any check on that, your entire surgery is going to be based on your erroneous registration. With the CT basis, that's virtually impossible because it's going to take this data and compare it to the CT, and if it matches up, then you know you're good. There's no garbage in, garbage out anymore. That's pretty much eliminated, which is different from a non-image based system or even a non-CT system.
Yeah, absolutely. So here, another cool aspect, that we've obviously some more research being done on differential cartilage thickness. So one of the interesting things, obviously, plunge down a subchondral bone, like to be at a 0 or half. But if I rest it on cartilage, you know, it's 1.5 there, 2.5 maybe here at the thickest part, plunge through where it's 0. So those are, you know, 0.5 millimeter adjustments we could make to the plan if we wanted to. So anyway, I'm happy with registration. This is the point in time that if you were going to do functional alignment or any kind of gap bouncing, would take your osteophytes here, balance, get your gaps, make whatever adjustments you're going to make. But we're not doing that, so we're not going to do that.
DA, I would think that digital measurement with that digitizer of the cartilage thickness is beneficial for KA users rather than using a caliper and not knowing, making a lot of assumptions. Here, you have the ability to really measure it objectively if you want to.
Yeah, for sure. I mean, at one point in time, and I'll talk about it when I make the resections, we were doing caliper verified. Became clear that this is so accurate, it didn't make sense to me to use an analog thing to check something that I knew was more accurate. So I'm at the point now that if I pass registration and the depths are all appropriate, we're blown and going. So I'm not checking as we go in between. I would certainly, if you feel like you know, to check until you feel confident in it. But I mean, you want to cut to 4 and 1. We don't measure the posterior before doing the rest. We just know it's going to be, know we're going to be in good shape. If I can get this tibia out in one piece, hopefully you'll be able to see that. So,
DA, real quick, sorry
yes,
to interrupt.
sir.
Are you going to go to the balancing screen, or can you show that balancing screen in the
of
middle?
course.
Just to show people who might want to look at that.
Here, yeah.
And I'll show it in my talk as well. So we'll show kind of a balanced out knee as well.
Right. But if someone wanted to, here's
Which
a
one?
screen where you can assess gaps on that right tab, and then plan implant. It'll show you your
see it.
implants, your sizes. So if you
There.
really wanted to measure the gaps or look at what your planned cuts would be and resections with implant on or off, all those functions are available there. So there's the gaps showing up live as they're assessed.
Right, and I think it's pretty cool. It can be assessed through, in some degrees, through an arc of motion, which I think is cool. And so, I mean, yeah, I struggle to figure out which ones I want to do unrestricted K for and which ones I want to do functional alignment, gap balancing type stuff. I think they both work really well, which is why I think it's hard for one to demonstrate superiority of one over another.
Thanks for showing that screen. I know you don't use it with KA, but thank you.
Yeah, of course. All right. So this is the TMINI robot. Obviously, pretty unintrusive, like everything else. So again, you can adjust which pins you're going to place with this number on the back. I work from tibia on the way up, and so I hold the trigger. That tells it that I'm ready to work. It will only power as long as I'm in line. If I go too far down, too far up, it shuts off. When these white lines are collinear, you know that you're ready for action.
Simple to use. What has been your experience moving from the larger robotic platforms, the bigger arms, trying to see around them versus using a handheld in the OR? How's that affected your guys' workflows?
Is that a question?
I
for
just like
panel?
the pin-based workflow a little bit better. You know, it's less noisy and less vibration on my hand. And like Alex said, you can actually see what you're doing as you're doing it. And then the biggest thing is just more fun. Right? Like the day goes by quicker when you're having fun, and this just feels more like you're doing a real knee replacement. Whereas using those big clunky robotic arms, takes some of the fun out of doing the surgery, I think.
Yeah, I think what's nice is that the pins are nice and easy to place, right? And then when you go to actually do your cuts, the robot's done, right? So then you put your jigs on, you cut it all safely with the appropriate retractors, and I think that makes it really easy, right? Look, just the robot is done with all it needs to do, and you can everyone can come in and protect the soft tissues and whatnot.
Yeah, for me, I mean, just by way of background, I've come from a background of having done, many thousand knees with a different system, an arm-based system, and got proficient enough with that doing it is easy, but the spatial sort of relationship of everything, that's really nice to not have any intrusion on like the space around the operating table, and then the accuracy is there. So the one thing I'd say that I've been most pleasantly surprised. I'm not even surprised. I was kind of expecting to see it, and I have seen it. Is
Right.
the block-based system on the femoral side? I've noticed a better cohesion of the cuts. I mentioned this in my presentation too. But any one cut by themselves, I think the accuracy is comparable. But all cuts together seems to be a little bit more precise and accurate with the block-based system.
The DA, you were too fast. I think if we blink, we missed it. Use that robot in about 60 seconds. You get all the pins in.
Yeah, well, I mean, I really, one of the things I like about this system is I really don't feel like it slows me down a whole lot. I mean, certainly, as opposed to doing a manual knee, this is, a few minutes slower on the front end. But if you factor in the amount of times that you have to recut and, the brain power to do it, it's an easy investment on my end. Pin driver?
Right, so for those of you not familiar, these pins are placed, right? That distal femoral pin that you just put in, that's going to put the universal cut guide in the exact depth and plane and rotation that he had planned on the planning screen. And same here with the 4-in-1. Basically what he's doing is he's setting where he's going to use this is a guide which is specific to the implant company he's using. But because the TMINI doesn't control medial lateral distance, it can set the plane and the rotation and height of that 4-in-1, but now he's going to drill the two lug holes basically just to match the 4-in-1 specific to the implant company he's using. So that's why he's doing this part.
I think what's beautiful is what you don't realize is that the robotic part is done, right? And one of those things of technology, when it's in the background, that's when it's the best, right? You don't even realize that the robotic part of the case, the whole case was over in about 60 seconds, right? And now we're just kind of executing the rest of the cuts.
And compared to the large platform robotic arms we were talking about, right? What I like about this handheld is it's completely sterile. You don't have to worry about robotic arms, their sterility coming in and out of the OR field, who's bumping into it, or is it stable on the edge of the table. It's nice just to have a single sterile robot you can use. And then to your point, John, you were mentioning how having a 4-in-1 like this secured down to bone, I agree, probably gives you the most reliable femoral preparation for example, a cementless implant. If you're doing a robotic large arm technology and you're making these 6 individual cuts, there'll be some error. You stack those errors, the implant doesn't always fit exactly as you want to, but this 4-in-1 fixed to bone really should be the gold standard in relation to each other.
Yeah, I mean, there has to be some movement, right? When you're making a cut, there's some sort of micro movements of whether it's your hand, the saw, the patient, and in a system like this, everything moves together. So it really doesn't matter if there's a little bit of movement.
And then the other thing I like compared to the large robotic arms is here, DA, you got to do feel it go through the second cortex. To me, that's always reassuring. With the larger robotic platforms, I had difficulty, particularly cutting the posterior condyles, either feeling it or seeing it, knowing when I was through. It's nice using standard saw instruments to feel that and see it.
I was going to say, just on the previous topic, we're going so much press fit now that having the cohesion of the cuts for me is really important, because I find myself accepting less perfect cuts, especially on the chamfers with other systems, and here pretty much the implant sits every time completely flush.
See you, Roger. Yeah, I think Dr. Lawrie makes a great point that for one of the advantages about unrestricted KA is the moment all 6 pins are in, you're done. You can take all the arrays off, send it into the next room. And I would say for, like I said, the lion's share of my knees, that is the case. And I don't, typically run 2 rooms like I think most people do, and I don't have any issues with delay or anything like that, which is really nice. Yeah.
I think this is a nice part, right? Because the you can get your nice exposure here of your tibia, do it safely, right? Because the robotic part's already done, right? So everyone can come in and protect what needs to be protected.
Right.
The DA has the confidence that he's cutting this tibia at whatever degree varus he planned and whatever height and depth he wanted, so he doesn't have to recut. He'll have the appropriate amount of gaps to accept the smallest liner. But this is definitely time savings when you don't have to recut the tibia.
Yeah, 100%.
And again, throughout this procedure, you've noticed that you're not changing the leg position a lot. You don't have to move or struggle. And, this is a good-sized Texas small leg, but, the bigger legs as well, this technology really seems to make them all equally as simple, because you only have to expose the distal and anterior femur, a little bit of the anterior tibia. You don't have to fight to get to the back of the knee. You don't have to fight to get to the back of the tibia, because with the CT, you really only just have to put the pins in on the portions of the knee that are exposed. So you can see DA's doing a great job of it being a minimally invasive approach, subvascus, with the knee not moving a lot during the whole procedure. It just makes it much simpler. Even in the stiff knees, the large knees, the bigger knees, I find this technology makes them all basically similar.
All right, for the most part, missing 10%, that's better than usual. So yeah, this was the thing that sold me on this technology, is that this was right on every time. The femur is not as challenging manual, but the tibia is. There's just no doubt about it. And I don't even really take it out and enjoy it much anymore, because now we're just going. But this is what we're shooting for with unrestricted K every time. So a huge advantage as far as I'm concerned.
I thought the part you loved, DA, is you didn't have to pull out your calipers anymore. You don't have to try to measure that thing.
That's right. That's right. Hey, listen, it's 2025. We don't need those any longer, guys. I'm just kidding. If there's hardliners in the crowd, that was a joke. I mean, it's not really a joke, but take it as a joke.
How about doing 2 rooms? How about doing something like this, using this technology, bouncing back and forth? Whether it's your hospital or your ASC, how is it compared to the other robotic platforms you've used?
I think as you were saying, from a size and OR footprint perspective, I don't think there's really any comparison. And then, like I said, because we're doing, especially if you're doing unrestricted KA, the total time that the robot is in that person is like 15 minutes maybe until the pins are in. So I think it can be out of the room and on to the next. Let me see, Roger. About as fast as possible. I don't know if the other panelists have had a similar experience.
Yeah, I think what we didn't get to see was his OR staff setting the case up. The setup for this is very, very straightforward. It's only one tray that all the instruments come in for the robot. The draping is very simple. It takes them 5 or 6 minutes to do all the registration. And it can be done either while you're starting your exposure, if you're really running your rooms pretty tight to each other, or before you get in the OR. But my staff actually have told me that they prefer this system over the other ones because the setup is much easier and much quicker.
Yeah, there's just less to move. That's the one. I guess there's 2 things I think about. One, there's less to move. That's easier, faster. The other thing is, you hate to think this way, but it's reality. And if you think about, like, I don't know, worst case scenarios. I guess it's not worst case scenarios, but if something were to happen with the robot, right? Like, very easy to troubleshoot that with this system. Whereas with a single robotic arm, there's no troubleshooting that, at least not that day. So you really don't have that issue here, and that's something that doesn't come up often with any systems, but when it does, I actually have never had that happen with this system. I have with other systems, and that pretty much shuts down for the day. Whereas this, you just go on to the next one.
Yeah, I think in terms of storage, right, in terms of space in an ASC where you don't have a lot of rooms, just storing the single tower with the camera on it is much easier, takes up less space, and then moving from room to room, you only have to move that single console tower. You don't have to move a large platform robot with 2 machines on both sides of a sterile field, right? Because otherwise you'd have to move both pieces around both sides of the table to that next room. So it's certainly nice to have something that's more mobile and easier. And as you notice, there's no product specialist. The rep's not running around. You don't need to worry about the quality of your product specialist to do robotics in this case. It's all surgeon driven. He's doing it all himself.
Yeah, I can hear him.
How about the impact on your OR staff? No OR staff likes a new technology.
No
How was
doubt.
it when you brought this in to your team, a new system?
I think with a good healthy amount of criticism. Lauren, you've loved it from the beginning, right? Yeah, she's not. I mean, I think was pretty rapidly adopted. It's obviously I can't speak to the setup side as much, and I'm spoiled because Lauren, I think, is the best scrub tech on the planet. So, I mean, I think I think it was adopted pretty quickly. I don't know. We just don't have issues in that regard. And I mean, certainly starting my career, I was trying everything. So I was always keeping folks on their toes. So maybe they just never got the chance to get comfortable. So I don't know. We'll see if I use this for the foreseeable future, which I anticipate I will. Hopefully, won't have as much issue in that regard. Yeah.
We have a lot of robots at our institution, and I would say there was no question that this was the hand-down easiest to set up. In fact, usually the scrub techs, there's nothing to do with the robot, right? That's sterile. The only drape that you have to put on is really on the screen and the tower, which is basically a skirt and a sleeve. So that's like prepping a Mayo stand. So from that standpoint, it's quite seamless. A huge benefit.
We found in our institution the learning curve for the staff to register it and set it up was much faster, as you said, and they all prefer it over the other robots. It's just so simple to use. We've even had scrub techs who've had zero ortho experience or zero knee replacement experience, and they can do this case quite simply. So they actually all prefer it. So when we have visitors come to our ORs or centers, it's amazing to see how the staff, the OR techs prefer it, the assistants, whether it's a PA or surgical assistant, they all appreciate the workflows, and then, for surgeons as well, it's just much easier, so all around. And not to mention the reps.
Roger.
They've all preferred it as well.
Don't mind me just digging in the back of this knee. All right, so let's float. We'll float our trials here.
Are there any cases or patients you guys think that you can't use this on?
I don't know that I've found one of those yet. Let me see this.
I would say no. I mean, I've been probably using the system. I'd say the shortest out of all of the panel members, but again, having a lot of experience with other things too. I think sometimes there's a thought that using any technology, including this one, it's going to be helpful for my complex knees, whereas I can do my straightforward knees manually, and I'm sure that's all true. But I think if you ask yourself the fundamental question of, okay, A, what are my goals in surgery, and then B, can this help me achieve those goals? It would be hard for me to answer no to that question for any case.
Hey, Tom, I know you like to push.
Yeah, I mean, I think I'm using robotics for all my cases. All knees get robotics, and I don't think there's any case that this, doesn't preclude me from using it. Now, obviously, there's really complex cases where I'm doing primary hinges down the. I try to use TMINI for every case.
Yeah, I agree. DA, show us what you got there.
Yeah, so I mean, before I even look at these numbers, I like to feel it clinically, see how it feels, and I think we're in a good spot. Seems straight to me. Obviously, can check here, so it says we have a little bit of hyperextension. We'll see if that's. I'm not sure I believe it, but I don't mind putting another millimeter or two of poly in, and then, but just looking at the gaps, pretty symmetric, one side to the other, coming into flexion. Maybe a little bit of slide. Obviously, with a medial pivot, you want more of a rotational thing. So I think going up a millimeter seems appropriate. Checking amount of flexion. That's pretty good for a Texas small. So I think we're gonna take these parts at this point. We'll prep everything, rays come off, and we'll put the final stuff in.
So just to clarify, when he says he's not sure if he believes that hyperextension number is real, that's not an inaccuracy of the TMINI system. That's all CT-based robots, because it can't take into account femoral aneversion as it's drawing the femoral mechanical axis. So any robotic system on the planet that's using CT, you have to take that extension number with a grain of salt.
Right.
Even the non-CT based systems as well. I mean, I use plenty of non-CT, and you just, the flexion extension, I would say there's a little bit of, when I first start the case, and we didn't do it here, I just hang the knee and I think what I like, and then I look at what the robot says, and that usually gives me kind of a baseline. But yeah, there's inaccuracies to where the center of head is compared to the knee. So you have to kind of figure out what you want to get.
Yeah,
DA, you've liked the medial pivot type designs or those philosophies with the KA approach?
Yeah, it's it was somewhat, I guess, the natural evolution of that, of me just delving into that balancing philosophy. I mean, I do like the medial pivot design. I know there's question about, is there lateral pivot? I'm not smart enough to know the answer to that, so I'll wait for someone who's smarter than me to figure that out definitively. But yeah, I mean, purely from a patient satisfaction perspective, enough for me to notice. I remember I had a lady in clinic telling me last week, she has a PS knee on one side, loves it, and so I had to I saw her for a post-op last week, but I had to tell her, I was like, well, I'm about to show you these models, because if I put what you have in and you don't do well, I'm gonna feel like an idiot because I don't wanna do that. But if I do something different and you don't do well, it's somehow gonna be my fault. Yep, this is it. And so anyway, saw her post-op. She loves the medial pivot, but she told me, I said, well, what is it you like about it? And she said, I liked it when I'm shaving my legs in the shower, I can just pick this foot up and balance on this one alone, and I can't do that on the other side. And I'm like, I'm not sure I could balance on one foot and shave my legs. Don't have a lot of practice, but anyway, I thought that was pretty neat, something that stuck with me.
Just curious, going down the panel, Eytan, what do you think your learning curve was in terms of getting, more or less steady state for your case times, and how many cases have you done to date?
Yeah, great question. So I think for me, I came to this with a large amount of robotics experience. So I think it depends on what you're starting at. So for me, the idea of robotics and the balancing and the numbers, that part was more intuitive to me. Whereas for others, I think that will be the biggest challenge if you haven't done robotics. I think for me, some of the big ones for me were understanding where the pins to place, right? So you want to place them in good bone and trust the system to put them in the right place. I think that was one part for me that, because that's different than other places. Knowing where to put the overhead camera, because you can see how important it was to make sure the case goes really smooth without adjustments. And I think that was another kind of learning curve for me from that standpoint. And then the other is I was less CT based on my robotics. And now I'm kind of fully embraced the idea of a CT-based robot.
Talk about that, Eytan. Tell me what the benefits of the CT base compared to imageless.
Yeah, I think what we just talked about here, right? I think it gets you like 95% of the way there, right? This kind of reality of what the sizes are, the position, right? You're pretty much there. Now, if you want to do KA and adjust it that way, or you want to do gap balancing and adjust it based on the gaps, I think that's fair. But I think you're kind of almost there right at the start of the case, and to me that was a huge benefit, where it took a lot of guesswork out that I didn't even realize I was doing with the non-CT based systems.
And the efficiencies, right? Knowing the sizing going in. If you're in the ASC, you don't have to open up every tray of every size. You know ahead of time what your femur and tibia are going to be very reliably.
I mean, I think that
Secondary.
for me, the one additional thing, which for me personally might be the biggest thing, is the confidence in the registration. I'm not sure, and DA said it earlier, like I'll say it now, like I'm sure there are surgeons out there much better than me, but if you compile all my robotic experiences, thousands of knees, and I will still make occasional registration errors. So I'm not sure even now I would trust to have the occasional outlier wouldn't be acceptable to me. And the CT ensures you don't have any outlier. It will not allow you to pass the registration if your registration data doesn't match the CT data.
Builds trust. That's great. DA.
Yeah, I mean, I think the cool thing is, in today's day and age, I remember when I was even in training, one of the risks that we tell people about with joint replacement is, may not be balanced perfectly or balanced well. And I don't say that anymore because I'm just unwilling to leave the operating room unless I feel like the balance of the knee is really good. So for me, it's just so reproducible, which is wonderful. From a time perspective, even with us hanging out, we're at 33 minutes on the tourniquet, so it doesn't take long to have parts in, even for a slightly bigger patient. And so anyway, I mean, yeah, very happy with the end result. I think we're in full extension. Just to drive the knee around, feels great, don't see any lift off. And then in flexion, again, Even pulling medially doesn't do much. Pulling lateral shows you the rotation. For the subvastus aspect, you can see the quadriceps really isn't beat up. And then honestly, from a closure perspective, probably doesn't help most of us because most of us probably don't close, but it's way faster. I mean, you can see the corner right here, capsule, synovium underneath. That goes to the corner there. My deep closure is 1 Stratafix. 2 loops here to bring it together. I close it at 90 degrees, down and up, over and back, and then after that, we're onto the skin. So anyway, that's pretty much it. I appreciate it. Any questions for me or anything?
You made it look easy, DA. That looks great. What do you think, Eytan? You can do subvastus on Monday.
I'm going to try it out. That's beautifully done, really.
All right, thank you guys. I
I
appreciate
love that
it.
you're left-handed. I can go home and tell my son he can be a surgeon now. I told him before he couldn't.
Hey, there you go. I'm equally clumsy with both hands, so it's perfect.
There you go. DA, that was a great demonstration. Unrestricted KA, you know, with the subvastus, really quick and efficient, minimally invasive with robotic technology. You know, any questions from the audience? Why we luckily have DA here? Yeah.
Quick question. Do you make any changes to your plan, unrestricted K, with severe valgus knees, or are you still taking equal implant resections?
Yeah. Great question. Again, I'm not an unrestricted KA hardliner, right? For me, unrestricted KA is a tool, like this robot is a tool for me to get to a knee that's balanced well the way that I want. So for me, this is my own personal thing, it depends on their degree of their coronal alignment. So if they are a fixed significant valgus, I have zero problem making adjustments or changes. My tibial resection will almost always be the medial proximal tibial angle, but if someone is fixed valgus, I believe the IT band is pathologically contracted because that's a musculotendinous unit, so I cut that every time. Could I twist the parts to have it balanced well with that? Yes, but I think it's harder to get the coronal restoration of limb alignment, and you know, there are certainly patients that, especially valgus, that I think that they would value a straighter leg that's well balanced over a crooked leg that's well balanced just because they happen to have been bow-legged. That's my own personal belief. But like I said, that's the next thing I'm trying to figure out is who I'm going to functionally align, who I'm going to unrestricted KA, where the cutoff is, in what patients. So I think that's a great question. I can be pretty confident no one really knows the answer to that. They both do well.
Another question coming, DA. As that person's coming up, can you tell us what implant systems you've used so far, or maybe just down the panel as well? What implants have you used with this technology?
I have only used the Spherica with this technology. Have tried a bunch of different implants as I first got started, but I mean, this for me was technology to let me use what I thought was the best knee implant. So that's the only one that I have put in thus far.
Got it. Down the line, Eytan?
I've used both this implant as well as the Innovis implant, and I think what's interesting is with this implant agnostic kind of workflow, it's almost like you don't think about the implant. You're just doing the cuts and executing it, and then you can put in whatever you want in the end, which is really nice. It kind of divides the two.
Well, same as DA, but it's a different system from what I came from. And what I think is nice about this system is, the TMINI is, different implants probably should go in slightly different from one another. And, you know, I think it's another strength of the system that you have the flexibility and capability to do that based upon not just what you think for that particular knee, but also that particular implant system.
I've been exclusively using Zimmer Persona. I've used a lot of other implants on the market without this technology. Think basically offers 2 different versions of the robot. One of them is an exclusive Zimmer deal, and the other one is the open platform one. So I've got the Zimmer exclusive one, so that's why I've been using the Persona.
Local.
So I've used Zimmer and
Local.
Innovis, Medacta, Link. Who else is on there? United and TJO and Max, Ortho Development, B1. There's a number of other implant companies. So depending on whatever your philosophy is on implant design, there's probably an option for you, which again is great. You can pick implant design, implant company, surgical approach, alignment philosophy. All these options are up to you and with one robotic platform, which makes it unique. There was another question. Yes.
Yeah, Dr. Rajesh Manyar from Mumbai, India. Great demonstration, DA. The question is, do you ever feel a need to verify your cuts? You know, it's your blocks that you're using. They can move a little bit here.
Yeah, for sure. So so like I said, probably the first 20, I was very anal about measuring the resection. Every time I was looking oblique to the cut, passing a saw blade in, trying to make sure, and it became a waste of time every time, which is how I wanted it. This technology, I don't think would be worth as much if it was right 85, 90% of the time. So, I mean, yeah, my brain is still on. If a cut looks ridiculous, we kind of step back and make sure it looks good, but like I can't think of a time I've had that with this system. So the short answer is I kind of verified at the front end, and now I trust the technology.
Great.
So if you wanted to verify your cuts, you could either caliper them, like a KA surgeon would, or you can actually take that registration tool and lay it on the bony cut surface, and it will show you on the screen the bone being cut and how many millimeters you are from your plan. And I've been the same way. I've found that it is extremely accurate. What you plan for your anterior run out, avoiding notching. Persona's got a little hole in their cut guide where you can run a drill anteriorly to see if you're going to notch where the drill is going to come out. And I quit using it because whatever is on the screen visually for the run out is going to be exactly where that saw blade comes out. It's pretty incredible.
Great. Any other questions from the audience? DA, we can't thank you enough for letting us join you in the OR. We see where your alliances are with the Aggies there. Thanks for showing that.
That's right. I'm ready to be heard again. Hopefully it doesn't happen this weekend.
Yes. But that was a great demonstration. That was amazing. Thank you so much for letting us join you in the OR.
Awesome.
And we miss having you here, but we'll see you soon.
All right, sounds good. Thanks, guys. I'll see you all in the meeting here soon.
So we'll talk about why robotics and why TMINI. I think one big thing to be aware of is there are a lot of pros of robotics, right, that I think we all believe in, right? There are pros to TMINI over other robotic systems, but I think both are important to be aware of. So we'll talk about the reason for robotics and alternative alignments, talk about implant choice, real estate, which is important in Manhattan, and efficiency. So current state of robotics, it's exponentially rising. I think that's pretty obvious, and I don't have the most recent numbers, but over the last, I would say 25 years, there's been an exponential rise in robotic surgery, and it's here to stay. And I had a big conversation last night with another surgeon as to kind of, they're very good without robotics, and I think, but they know that robotics is coming, right? So I think, can it make you a better surgeon? I think most surgeons we talked about here, I think we're very good. I mean, to me, I tell my patients like this, it's like parallel parking a car. Like I can parallel park a car very well, but maybe I have to readjust, got to get closer to the curb so the garbage truck doesn't hit my mirror, right? This is classic Manhattan issues. And I would say with the cameras and sensors, right, you park the car the first time around perfectly, right? And that kind of gives a sense as to what's going on. I don't have the Cadillac that parks for me yet, and I would say that may be coming one day, but I would say right now, these cameras and sensors, once you use them, they're highly addictive, and I think that's where, you feel the real power of robotic tools. And I think most of AAHKS surgeons believe it, that it allows us to be more precise and more accurate. So greater component accuracy and precision, I think this is kind of proven time and time again. And I think I've become a little bit of a believer, well, not a little bit, I've become a believer in CT-based robotic planning for that reason. I did a lot, hundreds of cases without, a robotic system that did not have a CT-based plan. And I will say every so often you're like, gosh, that was not really where I thought I was, because it can be precise, but it may not be accurate. And with the CT-based systems, you can be both accurate and precise, which is really nice. All the other stuff, greater soft tissue protection, greater functional outcomes, reductions in pain, improvement in quality of life, I believe, but that's something our research lab is still kind of working hard to show. In terms of alignment strategies, mechanical alternative alignment, right, we mentioned functional alignment and we mentioned KA, but you could still do mechanical alignment with robotic tools as well. I think that most of us, however, have realized that probably most patients are not necessarily neutral mechanical alignment for both their femur and their tibia, and it gets a little bit more complex. In a standard varus, right, this is a patient with a 7-degree varus, but a lot of obliquity at their joint line. And I think, just looking at the wear patterns, if you want to cut these mechanical, you can see just the asymmetric cuts in a standard knee. And this is kind of a much older patient I did for, very early in practice, and metal allergy. And, I used this implant and just mechanically aligned, neutral alignment, high fives all around. But maybe there are subtle issues like, I don't know, standing on one leg and shaving your legs in the shower. I'm not sure. That hasn't been a question of ours. Maybe it should be. But I think that, the alternative is that there are other varus knees with a lot of obliquity, that we can achieve with robotic surgery in a way that we weren't able to do before. Like we mentioned, recuts of the tibia, but I would argue even primary cuts of a tibia in varus or valgus can be really challenging with manual instruments. It's really just not built out for that. And there are a lot of alternative alignment strategies out there, kinematic, inverse kinematics. I think the caliper-based systems, grew healthily in an environment where mechanical alignment was the primary goal, but in an environment without robotics, right? So, kind of doing KA beautifully without robotics is very cool, and I think mentally amazing. But I think with the advent of technology, you can really achieve this much better with robotic technology. And there's navigation robotics and unrestricted and restricted kinematics, and I think we can debate that all day. At the end of the day, these are the kind of balancing screens we see. We showed it here in the live surgery video, but you can kind of get all your gaps and all your balances, and we have them both live, so some surgeons want to see them constantly live. We also have them auto-captured in the center of the screen and really be able to kind of see where our numbers are. And then we can make adjustments, right? So we didn't do this live in surgery, and so you could do this pre-operatively. You could do it in the office. You can do it, right before you scrub in, right? You can make these adjustments, and then you can make them intraoperatively after you've done some of your balancing and gotten your gaps, right? And here there's pivoting tools. You can pivot centrally, you can pivot on the sides, and then you get these notch warnings if you're notching, and then we have all that built into the system in order to basically dial in exactly what you want to do. So what's nice in the video you just saw is that by doing the KA workflow, it was all done pre-op, and basically nothing was done intra-op. For me, I do make adjustments intraoperatively. That's just my workflow. I go more of a functional balancing type methodology. It is this case specifically. So there's another case example. A patient just a few days ago, varus knee, worst skin I've ever seen in my life, but I guess it was a New York City small, so BMI I think 16. So it was. So these are kind of the initial gaps, right? And you can kind of basically dial these in, right? So these are the gaps I get, and before you get these gaps, you want to take off your osteophytes. So you want to leave your osteophytes usually for registration. You take them off when you do your gaps, and these are the kind of gaps we would get. And then I can make adjustments to get those gaps a little bit more equal. This is also a whole other philosophy. Where do you want to be? These are kind of typical gaps I want to see for the implant system I was using at that time, and that's Dr. Tiberi was mentioning, it depends on the implant system you're using. Be aware, buyer beware, know your implant system a little bit. But these are the numbers that work well for the implant system we used, and kind of getting these final gap numbers that I like really is really helpful. And kind of these are the final images, obviously. PACU portable X-ray, not the greatest image, but it's in a good position where we want to be. So I think implant choice is a big deal. I think that there's all sorts of philosophies out there, and we can kind of debate them. Hypoallergenic, the medial pivot, the lateral pivot, the deep flexion, the dual pivot. There's semi-constrained, real constrained, patella friendly, not patella friendly. I have my, it's kind of like a religion. I have my beliefs, so we don't argue them. It's kind of politics. So I would say what's beautiful about this system is that you can kind of basically decide what you want to use at the end of the day, maybe with some tweaking, but allow you to use at least the same robotic system that you're used to, right? So the robotic system in my mind is like the surgical knife, right? It's a knife. It doesn't have to be married to the implant, right? And that's a beauty of this system, is that you can just become very good at the technology and then use whatever implant you believe in. I think different implants are important for different people, and we can debate that, but I think it really does matter. But with the TMINI system, you have that freedom of choice. I think real estate's important. I mean, I think, for us, even that OR was actually quite small for Texas. I was actually surprised. I even saw the anterior hip table hiding in the background. So I think, I thought there'd be even bigger ORs here, but I think at least in our system, our ORs are real small. So real estate's really important, and where you store these things is really important. That's a whole other thing. And this is just this TMINI system. This is the whole robot, and it's sterile. Efficiency, I think without a question, the efficiency curve for me has been really rapid. And I think it's been much more rapid than other robotic systems in terms of acquiring cases. Now, for me, I came from I'm a robotics user even before, so I think everyone will be a little bit different. But from an efficiency standpoint, it's really hard to kind of mess this up, really, in terms of those pin placements. There's not a lot of things that you can do wrong, but I would say definitely there are learning curves, and that's okay. And I would say obviously be patient when adopting new technology. So I think in conclusion, robotics are here to stay. Alignment strategies are simplified with it. There is choice, OR footprint matters, and efficiency is important. Thank you.
All right. Thanks. Yeah, I'm John Tiberi from Los Angeles. I'm going to show you what I do. It's what I do, just like we've been saying all along. You don't have to do it this way. I mean, there's so many ways you can do it. I think the take-home message really is from all of us is, whatever goals you decide you have in a knee replacement, this technology can help you achieve those goals. So first, just a couple of bullet points about appeal. For me personally, this is by no means an exhaustive list, but just a couple of things. I I do like the idea of implant variety options. I think that is very beneficial, whether it's just a comfort thing for you with a particular implant system. I think it's really more of a design thing. And yeah, maybe we do get to the point where for different patients, it calls for a different design. The overhead tracking, we've talked about it a lot, so I won't beat a dead horse, but it's got a significant advantage in the OR. Reduced footprint, we've also mentioned, and then I think there's some sort of technique and instrument options with the system that lead to efficiency. So this is my case example. It's a 70-year-old female with bilateral worsening knee pain. She had done a lot of the typical conservative management. And then, the exam just showed a varus aligned knee with some restriction in range of motion. And these are the x-rays. So it's a varus knee, complete loss of joint space in the medial compartment. There's this big loose body that radiologist drew a line on in the suprapatellar pouch, and that's our case. So this whole thing, as we've mentioned, starts with the CT. I think when image-based either navigation or robotics was emerging in the market, the CT got talked a lot about as this negative thing. And I'm not going to tell you there are no negatives to a CT. Of course, there's radiation exposure. But I think we are now realizing what a positive it is, or at least the positive aspects. And I think for most of us, if not all of us, we're starting to think it's an overwhelming advantage to the system. So as far as the planning goes, we've mentioned it. This is the particular planning screen you'll see. I know some of the text is hard to read on the presentation, but in real life it's easy. But in this particular plan, we've got a 3D model of the femur. We can look at that in any way we want, any plane we want. And in this system, we can choose which implant we want to use, the size, which is this first red box. Kind of our next red box here is sort of position. You can configure the position in all three planes any way you want. And then finally, this gives you some resection amounts, which can be adjusted based upon your position. So it's kind of a starting point. You can decide what you want your starting point. DA's starting point, my starting point are going to be different because it's different philosophy. Same kind of thing you see on the tibia. Other things you can see here. There's like that tibial osteophyte on the medial side that we're seeing, and just some reminders, hey, intraoperatively, don't forget about this stuff. Next, you're going to do the registration. We saw that already done live. I just want to point out again, there's no garbage in, garbage out. Your registration will be accurate because you cannot pass this step without it being accurate. The congruency between the CT and your data collected ensures that. Then I do what's I call just an initial assessment. So I take my knee here, look at the top screen, and the first thing I do is place the knee in gravity extension. So I'm getting an assessment of what my flexion contracture is. In this case, it's 8 degrees. Okay, I'm going to use this later to help me decide how large I want my extension gap to be. The next thing I'll do is put the knee in gravity flexion, and I'll also make note of the coronal alignment. All three of these things I use for documentation purposes. I put them in my operative report, and I use all three actually for patient education and physical therapist education. So just one example would be, let's say someone's got severely restricted flexion. I like to tell the patient and the therapist, hey, this patient can only flex their knee to 85 degrees under spinal anesthetic, pre-op. So really have to emphasize flexion in this patient post-op. And it's a better assessment in the OR with the system than it is in your office, even though, that's good as well. So I use all this for that. Next thing I'm going to do here is I'm going to do a gap assessment. So first, I'll place a varus and valgus stress and extension. We kind of talked about this. If you look at the top screen, the large numbers on the left-hand side, the 20.5 and 14.5, those are going to remain live. But once I apply that stress, that red box, that static, it's saved there. Okay, same thing, I'm going to distract the knee inflection, and that blue box, that static is going to stay there. Okay, so I've basically captured my gap before we even made any resection. This is like putting the lamina spreaders in post-resection, but it's pre-resection. Then I'm going to make a determination of what is my goal for my gap, or gaps. An extension, I want an equal medial and lateral side. This is for me. And in this particular case, I'm deciding I want a 1 millimeter larger extension gap than my minimum implant thickness. The reason being, there was a flexion contracture of 8 degrees, and there's not a significant amount of posterior osteophyte that I'm going to remove in this case. I have found that the adage of 1 millimeter for 5 degrees is fairly accurate, but I may adjust that if there's a lot of posterior osteophyte. Inflection. My strategy is generally to make it 1 or 2 millimeters looser than my distraction numbers. And the reason for that, I captured this gap under some distraction force. If I make it the exact same size as the implant thickness, I'm asking that knee to live under that distraction, which I don't think is right. I think that's too tight. And then I think, like a lot of us, I want the knee a little bit looser on the lateral side in flexion. So here's what I did to get there. I applied some tibial varus because the knee was symmetrically tight medially, both flexion and extension. I applied a little bit of femoral varus because there was some residual extension tightness medially. And then similarly in flexion, to address that, I rotated the femur. So pretty minimal adjustments, 2 degrees of varus in the tibia, 1 femur, a couple of degrees of external rotation. And so essentially, before I've made any cut, I've balanced the knee, and I know that I'm not going to need to release any ligaments. In a really severely contracted knee, I may do both. And the way I look at that is, without a robot, I don't know if I can get it as balanced. I got the ligament releases at my disposal, but I don't have this. I am not good enough. I don't know if anyone's good enough to make a 1 degree cut on the femur by hand or with manual instruments. The next step would be obviously the execution. You saw that done by DA. I'm not going to kind of go over that. And then my final assessment, I like to place the knee through a range of motion. I do look a lot at the values I get. This knee is ranging from 2 to 134 degrees. I think that's pretty good. But yes, I will throw out there that you do have to remember it's a mechanical sagittal alignment of the femur, which takes into account the center of the head to the center of the knee. So if you're seeing something that's slightly different than what you're expecting, it's probably because of the anteversion. And then I do mostly a manual assessment of my balance. This post-op x-ray is probably the least important thing I'm going to show you. It's done in the recovery room, so I don't have full-length x-rays to show you. So my overall opinion, we've hit on most of these points. It offers a really accurate, advanced CT surgical planning. There's multiple implant options available. It allows for intraoperative dynamic gap and deformity assessment, and it throws some objectivity in there. Manually, we're subjective only. And with the robot, we have the subjective manual assessment and the objective numbers too. The execution is accurate and reproducible, and I would say as kind of a point between these two, we've got the software and the accuracy of the execution will allow you to make those fine-tune adjustments and believe that they're real. And the last, I do, as I mentioned before, think that a cut block-based a system that's mounted to the patient may have some advantages when it comes to cohesion of the femoral cuts. That's it.
All right. Well, thanks everyone for coming and sticking around. I promise we're almost there. So I'm going to talk about TMINI and Persona. I have some conflicts with Zimmer Biomet, so take this with a grain of salt. So I'll go over some highlights of the Persona system first and why I love TMINI with it. So why the Persona knee system boils down to these 4 things. 1, sizing. 2, fit. 3, bearing options. And 4, the cemented versus cementless options. So sizing, this Persona knee system has more femoral component sizes than anything else on the market. 2 millimeter increments between sizes except the largest, and available in standard and narrow options, which in that valgus knee, the narrow option actually has a more valgus trochlear angle, which can help you out with a little patellar tracking. This is showing the trial that has the narrow cutouts on the side there, and this is showing a narrow femur where the marker was used to actually mark in those cutouts, just highlighting how narrow that narrow femur is. It's actually narrower than 2 sizes smaller than that size. So a 9 narrow is actually smaller than a 7 femur in the Persona. Fit, they did a really nice job with the tibia to maximize tibial coverage. They took actual resected bone when they designed this implant and designed the tibial base plate off of that. The sizing grows asymmetrically, medially and laterally to match what the native knee does as it gets bigger or smaller. Bearing options, if you don't like the bearing options on Persona knee, then I'm not sure you should be doing knee replacement because I think it has just about everything under the sun a little bit for everyone, including a constrained option in a primary setting. And then finally, you have the press fit and the cemented options with the identical prep with the new implant. So you can wait until the very last minute if you want to go cemented or press fit. So why Persona knee? These 4 things I think make it a great system to use. We're very lucky that Zimmer entered a partnership agreement with Think Surgical to allow us to use the Persona with the TMINI, which we've heard all about so far, so I won't beat a dead horse here. But why do I love TMINI? It's efficient. There's one tray, as I mentioned. This is very helpful in the ASC where you're worried about storage, worried about back table space, worried about setup times. One tray has everything you need to do the robotic case, and it's a very well organized tray, I will say. The setup time, as I mentioned, is quite fast. It has a small footprint with minimal line of sight issues. Very straightforward workflow that we've now seen twice, once in the video and once in the last presentation. The CT planning I'm addicted to. Once you start using it, you'll see the benefits. You won't be able to get away from it. Easy to recover in case of robotic error, and like I mentioned earlier, it's fun. So here's that one tray. You can see here, very well organized, everything stuffed into one tray. Fast setup here. We have my scrub tech here. Battery's gonna go in. I think it's gonna go out of order. She's registering the array there in the middle. I'm not sure if the other videos are gonna play. There we go. She's registering the other array there on the right side of the screen. Just a simple Z motion registers it quickly. And this was supposed to play first, but this is the rep in the room putting the battery into the TMINI. She'll latch the door closed, and then we're good to go on the robot, and everything is sterile now. So battery goes in, TMINI will home here, register itself, and then you would register the two arrays, and you're done. So like I said, from the time she takes the lid off of that tray to the time the TMINI is ready to rock and the drape is on the screen, it's 5 minutes or less every time. And I think the learning curve for the staff is very, very small as well, because it's really very simple, very straightforward, very intuitive for them to do, and the instructions on the screen guide them right through it. Small footprint, we've seen this over and over and over for the past hour and a half, but it can't be emphasized enough, that feeling when you walk in the room and it's like the robot is not there. Plenty of room for your assistants. We train fellows at our institution. We have plenty of help around the table. It can get quite crowded in the small ORs, so having something that isn't blocking the view of maybe a student or the fellow or someone wanting to stand in a certain place is very important for me. And you can see here we have basically 3 people right around the operating room table here without any conflict with the system, because we're using that vertical real estate that isn't used for anything else in the operating room. So here's just a couple pictures showing my typical setup where I'm standing on the same side of the table as my fellow, and my rep's taking the picture here showing basically we have unobstructed room on that side of the table, and then both proximal and distal to that TMINI unit, you could have assistants standing there if needed on the opposite side of the table. And they're not going to have any line of sight issues blocking cameras because, again, we're looking from top down at those arrays. Surgeon-driven workflow, we've been through this already. The registration is quite straightforward. There's a bit of a learning curve to figuring out kind of which hand to put the tool in and holding it still as you're clicking. I think using 2 hands like I've shown here is the way to go, because it really helps stabilize the pointer probe as it's going into the bone. Register tibia and femur, we do the motion, get our gaps, and then the planning screen. I think a really nice job was done here with the planning screen. It's quite challenging in these software packages to visualize all the relevant information in one concise screen. And I think whoever designed this screen did a very nice job making it both easy to look at as well as very intuitive to use. And then that CT-based planning allows you to have those 3 different pivot points for adjusting the implants, which for those of you who have used robotics understand the value of that. For those of you who don't use robotics yet and are thinking about it, having these pivot points really makes it a lot easier to make the changes that you want to make. Having a pivot point just in the middle of the bone means you have to rotate and then either move the bone proximal or distal, and it just adds extra clicks and extra steps. So I really find this screen very, very easy to use, and I like the way it's presented. The CT planning, so we've seen this screen before. Those basically what happens when your patient gets a CT scan with the Think Surgical protocol, which is a whole bone protocol, different than the other systems on the market. So it's going to go from the hip all the way down to the ankle without interruption, which, by the way, that allows you to do that quick flexion extension maneuver to find the hip center as opposed to having to do the circles to find it. Patient gets the CT scan. CT scan is going to get picked up by your rep. They're going to send it to Think Surgical. They're going to do all the segmentation and initial planning. It'll come back to your rep. You'll have a computer station at your hospital or in your office where you can tweak or fine tune this plan. I just have my reps do it at this point because he's up and running, and I don't need to look at it until I walk into the OR that way. But if you wanted to, you could really sit down and scrutinize these plans. You could adjust where the reference points are going to be for the resections and the gap measurements. You can even change some of the points where you're actually registering the bone if you think there's areas in a certain case that may not be accessible. So you really have good freedom here in the planning. The other thing that's nice in the planning is you can think what your default setting should be. So, I'm sure our surgeon earlier who prefers, unrestricted kinematic alignment, he probably has it set up so all of his plans come back with the KA resections as the plan. For me, I just looked at my first 20 cases. I do more of a functional alignment. Had him look at my first 20 cases, took my average resections of those and made those my default settings. And what that does is it minimizes the number of clicks that you have to do on the planning screen to achieve the balance and the resections that you want. So having that ability to customize that instead of having to have somebody do that manually every case is actually a big step in efficiency. So you just see here, turning that 3D model around before surgery. We've seen this over and over, but I think the value can't be understated, knowing where the osteophytes are, what the alignment is ahead of time, any bony defects, cysts, anything, you're gonna see it here on the CT scan, which is great. For me, CT planning is important, and we've heard this before. What you plan is what you get, which really should be the table stakes for robotic systems. Unfortunately, I think some of them fall short of doing this. But there's nothing worse than going through all the motions of the robotic surgery, getting to the end of the case, and then you find that what you worked so hard for, or maybe not so hard for with this system, isn't exactly what you thought it was going to be. I was shocked and amazed that using the pins on that guide is as accurate as it is, but truly every case, you plan it, you get to the end of the case, you feel the knee, and you're like, wow, that's exactly what I thought it was going to feel like. So I think big time savings there. Rare recuts are needed. Quick recovery in case of error. Errors are not very common. I think I've had this happen maybe one time. I've had it happen with the other robotic systems that I use. When that happens, it's a disaster, right? You've got the patient on the table. At our institution, our consent forms actually say total knee replacement with robotic assistance. So if the robot dies before I start the case, technically I am not doing the procedure that they have consented for. With the big robots, if you don't have an extra robot in the hospital and that thing dies, they're on the phone with customer support, they're pulling wires out of it, they're opening up the hood. At the end of the day, it doesn't work, and you're stuck doing a manual knee. With this system, if the robot dies or craps out or has an error for some reason, you have two handpieces when you get a tower. So you're just going to swap out the handpiece that's not working, bring one in that does work, and you move on. So that redundancy in that system is like having two whole robotic systems in your hospital, but you've really only paid for one. And then finally, like I mentioned, it's fun. I really enjoy using the TMINI handpiece. I think the ergonomics, the actual experience of putting those pins in is nice, and it feels like very futuristic when you're doing it, very straightforward. So with that, efficiency, small footprint, straightforward surgeon-driven workflow, CT planning is highly accurate, easy recovery in case of error, and it's fun are my main reasons for why I like using TMINI. And TMINI Persona, the perfect pair. Thank you.
I think just for the sake of time, I'm going to skip over my presentation and just open up to questions. So if there are any questions on the floor, feel free to ask, or if any comments from the panel. While we're waiting to see if there are any questions, Eytan, I'm just going to ask you, why do you think robotics hasn't been adopted even faster up till now? Why is it 15%? What do you think the market's waiting for? Is it just they haven't been ready? Is it not the right platform available? What do you think?
I think it's probably multifactorial. I think there's probably both. It probably started as more of a surgeon kind of learning curve issue. Do I need it? How good is it? Is it good for my patients? And I think we're at the point that most feel that robotics adds. Now, granted, that's probably one challenge, and that'll take time. I think another is that there's a little bit of kind of, for the hospital systems, is a little bit of kind of this robot exhaustion. You buy one system, it fits for like 3 of your surgeons, but then the others all want this robot, and you've just spent this much money. And I think that's been another big hurdle for robotics. And I think when you have this particular open platform system, I think that helps a lot for some of these medical systems, these hospital systems where they can buy one robot. It could be great for surgery centers, it could be great for the hospital, but it has multiple implants out there. So I think with that, I think you're going to see a lot more users and using it effectively.
Yeah, I think the ease of adoption, making it really the robot for the masses, where really any surgeon can do this and do it well, I think will help adoption. And then also, as you said, you can have a single robot potentially in your ASC with 5 different surgeons using 5 different implants with 5 different implant philosophies, but have one robot there. I think that will also help.
Yeah, I really think that that's the answer. I mean, I started using robotics in some fashion in 2015, so I've been doing it for 10 years. And I think, initially, probably the biggest barrier was implant choice, because there was, not a variety of robotic options. And then I think as there became more options, I think there were some limitations with some of the competitive systems. And I think it hasn't been until recently. I mean, really, I think this is kind of the option that checks both boxes. I don't know that there is another one that offers both. So I think we'll see what happens.
I think it's been that the data really hasn't been there to support it, right? Like we as surgeons have done a very bad job of studying outcomes after knee replacement and studying the impact of various alignment strategies on patient outcomes, not standardizing things, using crude instruments like patient-reported outcome measures. Go home and look at what is actually in a KOOS score, and you'll laugh at it because those are the baseline questions, right? My patients want to go jogging and play tennis and do all these high-level activities, and we're asking them can you go up and down a staircase? I sure hope so, right? That's the bare minimum. So I think what we're finally starting to see is people publishing some research on real questions, early recovery is faster, outliers are lower. So, really bringing to light those benefits of the robotics. At the same time, we're seeing the alternative alignment strategies starting to come into themselves and figuring out, how we can make patients better through balancing with bony cuts, keeping their, femur more kinematic profile. So I think, that's why we're starting to hit that inflection point with the adoption now.
Have you had any trouble getting the pre-op CT covered in patients?
It's becoming less and less of an issue. Right now, I don't really have an issue with it. It's regional. Different areas, you're going to see different issues. The one that I was seeing the most is, if you do have any work comp in your practice, which I don't anymore, but at one point in time I did, that was the biggest barrier for me. Really, the commercial payers and Medicare, no issue. But I've also noticed a trend over time of that kind of going away.
Thanks.
Yeah, I've had no issues whatsoever getting CTs approved. It never comes to me from my medical assistants or anything else, denials or other things. As Charles said, in the worst case, if they're denied, these centers will do CTs for a couple $100. So patients are happy to do it. So not an issue at all. Yes?
Thank you all for a great presentation. With kinematic alignment, there's a lot of assumptions of 2 millimeters of cartilage. This has the ability to measure cartilage differential. Is anyone looking at that to understand how we advance kinematics as well, or is everyone just assuming 2 millimeters?
It's a great question. So it's no, you do not have to assume 2 millimeters. So we actually have a great kind of surgical technique, and you can see it on our website or YouTube, where I basically do a medactomy and I go through the workflow, and you can measure the amount of cartilage thickness, and then if you want to redo the calculations for your KA cuts based on the cartilage thicknesses, which you can do with this system because you can, once you registered everything, then and we showed it for a second, you can put your digitizer, which is what we call it, but the probe, along the bone or the cartilage, and you can kind of see how much cartilage is left along the different aspects. What we found, honestly, in the few that we did, is actually the posterior thickness is probably thicker than 2 millimeters, and distally it's been closer to around 2. And the tibia, it can be different depending on where you measure. But worth looking at. We haven't done research on it, but something you can do.
Great, thank you.
Yep.
Yeah, DA alluded to it. He basically ignored those soft tissue gaps. You can measure it, and you can do it purely kinematic, but hopefully Steve Howell's not in the room, maybe you can do a KA plus type of thing, right? Where you can do the kinematic velocities, but now add in a little extra information that you couldn't do with a caliper or other things.
Yeah, I'd add one additional comment, which kind of came up earlier. We were talking about data, and if there's any non-robotic users in the room who that's the barrier for you in considering robotics is lack of some data. One thing I would encourage you to think, I mean, data takes a long time to manifest, and also there's significant limitations in our measures, right? I mean, I think we all know that the outcome measures are not great at really detecting what we want to know. But I think what convinced me about robotics just in general is think about the goals you have in surgery and think about whether this system can help you achieve those goals. And I think I mentioned it earlier, but I think if you really learn about it, if the answer is no, then the answer is no, but I think it's going to be hard to say no. So again, I'm not saying data doesn't matter, right? Of course it does, but that's what I would encourage you to take away. If you're not currently a robotics user and that's a barrier for you, think about it that way.
Great point. Charles, one subtlety in your presentations, it looked like you were doing a bilateral knee in that example. And this system, it's so unintrusive that you can do a bilateral knee and not have to move the console. You can keep it where it is, as opposed to other robotics where you have to move everything around both sides. Here, because it's in that vertical space, you can leave it overhead and you don't have to change it. You can go to the second knee, still do your same workflow.
Yeah, that's a great point. I still hated every second of the bilateral knees that I did because it's the worst thing we do to ourselves, but the TMINI at least made it a little less painful.
Yeah, absolutely. Just highlights the simplicity of the system. Well, we only have a minute or two left. I just wanted to highlight or ask the panel one final question is, historically, as orthopedic surgeons, we've been focused on the design of an implant, and we would only use one implant historically because we believed in it. And then robotics came along, and suddenly we're starting to do surgeries, not caring at all what implant we put in, just based on the robotic technology. But now we have the opportunity with this system to choose the robot we prefer and the implant we prefer in terms of implant design or implant company. You think that that's going to give us more opportunities to do things perhaps better for our patients as the pendulum swings back towards implant design, since we can use the robot of our choice to do it?
Yeah, I think we've been, or at least myself, I've been tied more to instruments than the implants, right? Some companies had really good manual instruments, and some companies, the instruments were a little bit lousy. And now that we have the ultimate instrument to do the surgery the way we want to, those chains are unleashed.